ladies and gentlemen. Thank you for attending our annual NUH Urology Symposium. I'm Dr. Fiona Wu, and I'm chairing the session today. We are honored to be given this opportunity to share some urological knowledge with everyone here, and hopefully everyone will leave this symposium with some understanding of common urological conditions. Most of the time, we are faced with some abnormal results, and we have the need to visit the urologist. We aim to address some of the common urological conditions that patients face when they see us, and we hope to allay some of the fears and anxieties that you may have when you see us. So today with me are our presenters. First of all, we have Dr. Kelvin Chen, we have Dr. Wang Ziting, we have Dr. Kartik, and Dr. Chia Jin Yang is last. So next up, we will have a video of our head of department, Professor Edmund Cheong, to talk to us.
Ladies and gentlemen, I would like to warmly welcome you to this annual public symposium of the Department of Urology, National University Hospital. Today we have arranged a series of talks on common urological topics that I hope you will gain some insight from. Please allow me a few minutes to introduce the department to all of you. Now, NUH Urology, we provide a comprehensive service that covers virtually all subspecialties in urology. We treat a variety of urological conditions that include urologic cancers, comprising the 5 major cancers in urology in the urinary system, such as prostate, bladder, kidney, penile, and testicular cancers. We perform robotic surgery and advanced prostate diagnostics with MRI-guided robotic biopsies. Under neurourology service, we manage conditions such as urinary incontinence, as well as nerve injuries to the bladder or overactive bladder. We have a transplant team that looks after kidney and pancreas transplants and dialysis access surgeries. This team also perform minimally invasive, including robotic kidney surgeries. And we have also a service that deals with stone diseases, as well as prostate enlargement treatment, such as using minimally invasive treatment for BPH. We also have an andrology and male reproductive medicine service that deals with male sexual dysfunction and fertility issues. Our female urology and reconstructive urology manages conditions such as female incontinence, urinary tract infections, and upper tract reconstructive surgery. These are the staff of our department, comprising senior mentors, the senior consultants, associate consultants, and our senior resident physician. We are supported by in-flight trainees and residents, as well as our resident physicians. We have a urology center at NUH, which is a unique one-stop center where all outpatient day procedures and basic urological evaluations can be performed under one roof. This includes multi-specialty clinics, outpatient minor surgeries. We have a stone center that does extracorporeal shockwave lithotripsy, and also evaluations such as cystoscopy, which is to do an endoscope of the bladder, ultrasound studies, uroflow studies, as well as urodynamics for bladder conditions. We perform prostate biopsies, as well as treatments such as instilling chemotherapy and other therapies in the bladder for bladder cancers, percutaneous tibial nerve stimulation for neurological conditions of the bladder, as well as andrology treatments such as shockwave therapy. Aside from the clinical service, we are also actively involved in teaching the next generation of doctors and nurses, and also we perform a number of clinical research and clinical trials. We are supported also by a 30-strong urology center staff, comprising nurses as well as clinic assistants. As a department, we strive to be at the forefront of clinical development that includes developing newer diagnostic tests as well as adopting cutting-edge technology for treatment of various urological conditions. We also strive to look into how we can develop new treatments that can produce better clinical or treatment outcomes. I'd like to highlight that in recent years, we are one of the earliest adopters for some minimally invasive treatment for prostate enlargement that includes the application of clips to treat BPH. And also, just very last year, we also started to use thermotherapy that uses steam to treat prostate enlargement. We have a heavy focus on research, such as in being involved in clinical trials, basic laboratory research, as well as translational research that tries to bring our research outcomes into the clinical use from bench to bedside. And aside from that, the urology department also supported strongly the COVID-19 pandemic efforts of the hospital by being involved in clinical care of COVID patients through deployment of staff to various sections that required them, as well as we had volunteers in dormitory last year to perform swab tests for dorm workers. So I hope this has given you a flavor of the services as well as involvement of our department. And I would like to wish you all a very fruitful symposium. Thank you.
Thank you, Prof. Cheong, for the introduction of our department. Okay, so first up, we have Dr. Kevin Chen, who is going to talk about stone and treatment. So, Dr. Kevin, please.
Hi, very good Saturday morning to everybody. Thanks for joining us this morning. So this morning I'll be talking about urinary stones, how we treat these urinary stones, and the advice we give our patients to help prevent the formation of stones. So a brief outline of what I'll be talking about today. Basically, I'll be talking about what urinary stones are, as well as the symptoms that patients have when they have urinary stones, how we as doctors investigate for these kidney stones, and I'll be touching on some treatment options that we have, surgical treatment options of stones, and lastly, I'll be covering some advice we give our patients to prevent stone formation. Okay, so first up, what are urinary stones? So urinary stones are small hard deposits of minerals and acids that can be found inside the urine. Now these form in the kidney or in the urinary bladder. We know that there's a lifetime prevalence of 5 to 25%. Now lifetime prevalence is the proportion of a population who at some time in their life would experience such symptoms. And we know that over the years, the prevalence of these stones have been increasing. Men are at a higher risk of forming stones than women. And some of the components that these stones contain would be calcium, oxalate, phosphate, magnesium, uric acid, and as well as others. So if you look on the right, all these tiny fragments or bits of stones are actually what they would look like if you were to urinate out one of these stones, or we were to take them out from our patients. So a common question that we get as doctors would be, why am I the one who gets urinary stones, compared to everyone else? Now, actually, commonly for stones, there is no actual one single cause. It really happens when the components of urine are out of balance. So if your urine is concentrated and there are various types of minerals found in the urine, stones can start to crystallize, and they, when the conditions are ideal, these stones start to develop in people who are susceptible. So like I mentioned, when urine is more concentrated, these minerals can actually start to crystallize, and eventually they form bigger stones, and then they can break off and they can drop, or they can cause problems. Other common causes may be inherited metabolic disorders, kidney diseases. Gout can also predispose someone to having urinary stones, as well as some inflammatory bowel disease. So where can these stones be found? Now, the stones can form in the kidneys, right? The stones can also be present in the ureters. Now, the ureters is the tube that connects your kidney to your bladder. And when the stones break off from the kidneys and drop down, they pass through this tube known as the ureters. So you can actually have pain when these stones are found in the ureter. Lastly, stones can also be found in the urinary bladder. So what are the symptoms of stone? Most of the time, when the stones drop down from the kidney and pass through the ureter, you may experience pain in the flank. So from the back of the side where the kidney stone is, and it may come in waves. The pain may actually move from the back to the front, and you may experience some nausea and vomiting. There may be some blood found in the urine, or you may experience a slight burning sensation when you're passing urine. Sometimes when there's a concurrent infection, there may be some fever, or you may feel that you constantly have the urge to go and urinate. Many a times, stones may also be asymptomatic and picked up through routine health screening. So I'd like to touch a little bit on how we investigate for stones when you present to our clinic with such symptoms. So stones may be asymptomatic. They may go unnoticed until they drop into the ureter or cause pain and blood. And when this happens and we suspect that you may have urinary stones, we may order certain investigations to try and look for these stones, right? So these investigations, first up may be that of just a routine X-ray, right? A plain X-ray would be able to see a majority of stones. However, there are also stones such as uric acid stones that may not be so dark and hence not be seen well on the plain X-ray. We can also employ ultrasound scan to help us look for kidney stones. The benefit of ultrasound scan would be that it is also able to tell us whether the kidney is obstructed or not. And lastly, the gold standard scan that we actually do for patients we suspect to have kidney stones would be that of a CT scan. Now, a CT scan is one of the most accurate modalities that we have to diagnose kidney stones. So it is able to see 99% of kidney stones. It is also able to tell us whether there's any consequence of the kidney stones, for example, blockage of the urinary system. This comes with a slightly increased radiation exposure compared to an X-ray. So a bit about the treatment of these kidney stones. So you can see in this slide that we have various techniques that we use to treat kidney stones. We can blast them, we can drill them, and we can also more recently have the development of these powerful lasers where we can actually laser the stone. So there are various modalities that we have to try and fragment these stones when our patients do come in with stones that require treatment. So first up is what we call extracorporeal shockwave lithotripsy. So this works by using directed high energy shock waves to shatter the stone into tiny pieces. Now these smaller stone fragments can then be passed out from your urine. It may take weeks for the smaller stone fragments to completely pass from your system. And if you can see the picture on the right hand side, this is exactly what it would look like. So you will not be put under general anesthesia. You'll be awake during the procedure. On demand intravenous painkillers with a light sedative effect is usually given so that the pain is manageable during the procedure. Now, what to expect when you're undergoing ESWL or extracorporeal shockwave lithotripsy? It's done in our procedure room, in our clinic. As mentioned earlier, we give venous self-controlled analgesia. You'll be lying face up on a table with a soft pad that's placed on the back at the side where the stone is. We use X-ray to localize and target the stone, and each procedure, patients will usually receive 3,000 to 4,000 shocks, and the whole procedure would take roughly about 60 minutes. Thereafter, you'll be monitored in our recovery area before we discharge you. And usually, we would give you an appointment to come back and follow up in about 2 to 4 weeks' time with a repeat X-ray to see our success in the fragmentation of the stone. So some patients are not suitable for ESWL. So such patients, patients who are pregnant, stones that cannot be well seen on the X-ray, so they cannot be localized or targeted. Certain stones are very hard or very large, and these stones may not be suitable for this procedure as well. As with all procedures, there are some complications that may occur with ESWL. So you may experience some blood in the urine, some bruising on the back where the site of the treatment was given. Other rarer complications include more severe bleeding around the kidney. You may experience some discomfort when the stone fragments are actually passing out through the urinary system. And certain occasions, these stone fragments that are passing may block up the urinary system, which require further procedure. Now, second type of treatment that we commonly do in our center would be that of ureteric stone treatment. Now, ureteric stone treatment basically is the passage of a ureteroscope. So it's actually a camera device that we pass up the ureter. We directly visualize the stone. And these stones can be retrieved with a basket, or they can be lasered into smaller fragments. This procedure is commonly done under general anesthesia. If you look at the screen on the right, the video shows our laser effectively breaking the stone up into tiny, tiny pieces so that they can eventually be passed. So there's no additional cuts that's required on the skin for this procedure. We go through the urinary passage, and after complete fragmentation of the stone, sometimes a temporary ureteric stent may be applied into the ureter itself to allow for healing. Now this stent is temporary, so usually we keep it in for 2 to 4 weeks before removal. This procedure commonly done as a day procedure, and in some patients we may decide to keep them just overnight to observe for any complications. And the complications of a ureteric stone treatment would be obviously the risks involved in general anesthesia. Again, you can have some bleeding, some infection. Sometimes the stone is so big that you may need more than one procedure to completely eradicate the stone. Scarring can happen in the tube, the ureter that the stone is lodged in. This usually happens later on, maybe months. And when this happens, there may be subsequent procedures that's required to open up this tube again. Of course, very rare injuries, very rare complications will be injury to the bladder, the ureter, where we may need to repair the ureter in the end, but these are very, very, very rare complications. I'd like to move on to the one of the last another procedure that we do for large stones, right? So very big kidney stones will not be suitable for ESWL or ureteric stone treatment. Therefore, we employ what we call a percutaneous nephrolithotomy. As you can see, the stones are very, very big, and they are usually in the kidneys. Now, this procedure is slightly more invasive than the above two options that we mentioned. It involves passage of a tube or straw-like device directly into the kidney. And when the stones are visualized, they are broken down. And the benefit of this procedure is that because the stone burden is so large, we are able to directly suck out the stone fragments and effectively clear the kidney of all these stone fragments. So you can see on the picture on the right are the broken down stone fragments that we managed to evacuate from one of our patients. Now, what to expect? Now, this procedure is done under general anesthesia. A small incision is made at the site of the kidney where the stone is, and the nephroscope is directly passed into the kidney. And the stone is directly visualized and broken down either with laser, pneumatic, or drill, kind of like a drill device. Usually the stay for this procedure, because it's slightly more invasive, would be about 2 to 3 days. Some complications would be bleeding because we are passing the nephroscope directly through the kidney tissue, so there's a bit more risk of bleeding. Stones are usually much bigger and more complicated for these kind of patients, so the risk of urinary tract infection is there. There's a small risk of injury to surrounding organs, and sometimes if the bleeding is very severe, which is rare, additional procedures may be employed, such as blood transfusion or a procedure needed to stop the bleeding in the kidney. So because of the complicated nature of the stone, sometimes we may decide to use more than one puncture to completely clear the stone. So we all know prevention is always better than cure. You know, we try to avoid having to undergo surgery or having to undergo, you know, the pain of having stones. So this is a very important aspect of our care for our patients, is to advise them on certain dietary or lifestyle methods that can help them prevent stone formation. So what should I do, right? So, this is some general advice, is to increase your fluid consumption. Now, we try to aim for about 2 liters of urine production a day. We also need to factor in insensible losses through sweat, perspiration. So, for example, for somebody who is always indoors, the total amount of fluid that you drink may not need to be so high compared to somebody who is, working out in the sun or does regular exercise. But the general advice you can think of is that basically your urine should not be too yellow, right? Anything from colorless to pale yellow color would suggest that you are sufficiently hydrated. Reduce your salt intake, right? So don't take too much sodium in your diet. A low sodium diet is beneficial for the prevention of stones. The World Health Organization recommends a salt intake of 5 grams, but in Singapore, our average intake is 9 grams of salt daily. So you can see that we are among the higher part of the curve when we're talking about diet. If you look at an example or some examples of foods that contains a lot of salt would be like pad thai. If you think that eating Subway is healthy, think again. If you're ordering a 9-inch meatball sub, we usually order 6-inch. So, the sodium content for that would be close to about 1,300 milligrams of sodium, right? So that is still significant if you take, breakfast, lunch, and dinner, right? So other methods or other advice would be to reduce your meat intake. Also reduce the amount of oxalate-rich foods, such as peanuts, coffee, tea, spinach. So also remember to take enough calcium in your diet, right? So calcium is important in moderate amounts to actually prevent stone formation. Right? If you have too little calcium in your diet, it actually causes your body to excrete more oxalate, right? Oxalate is actually a stone promoter. Also, if you don't take enough calcium in diet, you're also at risk of, osteoporosis and other problems. Right? So in general, these are just dietary advice to help our patients try to manage their diets in order to prevent the risk of having stones. Of course, if a patient has recurrent urinary stone formation, we do have a very specialized stone clinic whereby we test your urine over 24 hours to see exactly what kind of minerals and salts that you are more prone to having in your urine in order to formulate a personalized diet and give you a personalized advice. Okay. Thank you. I'll pass the mic back to Dr. Fiona.
Thank you, Dr. Kevin, for the talk on stones. I'm sure we have some questions. So for everyone, please type it into the Q&A so that we can answer at the end of the session. And next up, we have Dr. Wang Ziting, who will speak to us about PSA, which is prostate-specific antigen, a test that is often done, and an abnormal result usually causes some anxiety. So now I'll pass it on to Dr. Wang. Please, thank you.
Okay, thanks, Dr. Fiona. So today we'll be talking about change tag a little bit. PSA, this thing that you might actually read about in the papers or hear about from your general practitioner. Okay, I'm sure all of you are not unfamiliar with these two faces. So besides being our Prime Minister, do you know what else they have in common? So 1 year apart, Mr. Goh Chok Tong and Mr. Lee Hsien Loong were both diagnosed with prostate cancer. They both underwent surgery for prostate cancer and are recovering well. So what is it about this condition that is that affects our Prime Minister, and what about it? So this is a very busy slide. Let me walk you through it. So the general idea is that in the last 3 decades, there is more and more cancers that are being diagnosed, but with each with each decade, the death rates is actually coming down. So what does this mean? This means that we are actually getting better at treating the cancers. So amongst men, colorectal is the top one cancer affecting them. Prostate is number 2 and lung is number 3. but the prognosis of these three cancers are very, very different. So you can look at the last bit of the slide that says survival. So after 5 years after diagnosis, 87% of men who are diagnosed with prostate cancer are still alive, compared to 14% of men who are diagnosed with lung cancer. So you can see here that there are very different diseases with very different prognosis. So today we're going to be talking about prostate cancer and the three ABLEs. The first thing is prostate cancer is very discoverable, depending on how we investigate it. Second thing is it is treatable. And the whole idea behind all these things is that we don't want to wait until it is sizable. So what is a prostate? A prostate is a gland that sits below the bladder. You can see the yellow roundish organ below the bladder. And what does it do? It actually produces a fluid that nourishes the sperm. With age, prostate actually grows in size, and because it sits below the bladder, it can actually cause urinary symptoms. So who gets prostate cancer? The top left, you can see this is the Emperor of Japan. He's a very avid sportsman. He skis, he plays tennis, and that's where he actually met his wife. He was diagnosed with prostate cancer 2 decades ago and underwent treatment. So, I mean, he's still very well and healthy, and he's planning for a trip to UK. The next gentleman is Mr. Rudy Giuliani. He's the previous mayor of New York. He has a strong family history of prostate cancer. His father died of prostate cancer. So he underwent a different form of treatment. He had radiotherapy, and now he's more than 1 decade clear of prostate cancer. That on the bottom left is Sir Ian McKellen. I think some of you guys may know him as Gandalf of Lord of the Rings. So he was diagnosed with a lower grade of prostate cancer, and he didn't undergo any form of surgery or radiotherapy. In fact, he is currently under active surveillance. This is also another form of treatment that I will introduce to you all later on. And finally, on the right, that is Jackie Chan. His father survived World War II, survived the Chinese Civil War, and he passed on from stage 4 prostate cancer at the age of 93. So prostate cancer is common and it can affect anybody. I mean, any guy. So who gets prostate cancer? So these are the risk factors. With age, the risk of getting prostate cancer increases. If you have a significant family history, there's also an increased risk, and also ethnicity. But that is not so applicable and not so common in Singapore. What we are referring to is actually African Americans and also Caribbeans. So a very common question, Doctor, can my diet affect my chances of getting prostate cancer? There is some evidence showing that increased alcohol, increased red meat or fatty food may increase your risk, but the evidence is very, very low. And also there's some very small studies that show that if you eat more phytoestrogens, it may also reduce the risk. But the short answer is, as in there's no strong evidence, I think probably the best approach is just to lead a healthy lifestyle, exercise, don't eat too much of the fatty food, don't smoke, etc. So how do you check for prostate cancer? There's always a question, right? I think the idea is we want to detect prostate cancer at an early stage so that we aim to treat rather than just control the disease. But as with everything in medicine, it's always a balance. You want to catch the cancer early, but you also don't want to over-investigate. So we usually start when the patient is at risk of prostate cancer, usually in patients who are 50 years old and above, or patients who have significant risk factors, like what I mentioned just now, like a family history. So when should I get a checkup? Oh, sorry, hang on. Okay. So when should you get a checkup? So there are certain symptoms that may suggest that you should get a checkup, such as when you have urinary symptoms like difficulties passing urine, you find it slower, you need to strain when you pass urine. After you pass, you still feel like passing again. You need to keep going to the toilet if there's blood in the urine, if you have a family history, etc. But that being said, that doesn't mean that you have prostate cancer. Okay, or so there are a lot of other causes that could also result in you have in the symptoms that I just mentioned. So this will include stones. These are stones in the bladder, what Calvin just talked about. And you may have urinary tract infections or diabetes or scarring in your urinary tract or an enlarged prostate that is not due to cancer. So basically, those symptoms, if you do have those symptoms, don't be alarmed. It's basically like like the indicators in your car. It just suggests that you should actually get a checkup, so that to catch things early, so that your car doesn't break down in the middle of the expressway. So what will happen when I see the doctor? So your doctor will do a physical examination. Sometimes they may do ultrasound, some form of imaging, and then now we come to the crux of this talk. Actually, the blood test is a simple blood test, what we call prostate-specific antigen, also known as PSA. So if you Google PSA, PSA has had a lot of bad press in the last 1 decade, actually. If you Google it, you'll see they talk about the disadvantages of PSA. They talk about what it is, why is it so controversial, why is it bad, etc., etc. So PSA itself is actually a very, it has an interesting story behind it. So there are actually 2 big studies that came out talking about PSA, whether it's beneficial or not. And we're talking about PSA screening. So basically they test it in men with no symptoms. And so there are 2 studies. The first one is actually a study that was performed in the United States. The second one was performed in Europe. So interestingly, the 2 studies actually showed very different results. The US study showed that there was no benefit. And the Europe study suggested that there was PSA screening actually reduced the risk of death from prostate cancer by 20%. So based on the US study, in 2012, the US Preventive Service Task Force, basically this task force that suggests guidelines, recommended against PSA test screening for prostate cancer. And what happened after that was that in US, they started the number of PSA screening reduced, and after that we started seeing the effects of this guidelines. So from 2012 onwards, the number of localized prostate cancer, meaning that early stage prostate cancer being diagnosed, dramatically dropped, and the number of distant prostate cancer, meaning that stage 4 prostate cancer, actually increased. And with that, there was also a further follow-up. So the European guys went on to do further studies, and they found that actually the benefit actually continued. So the benefit of PSA screening actually remained persistent. Whereas for PLCO, the US study, there were certain flaws that we found. So all this evidence led to the US Preventive Task Force basically revising their guidelines to a more balanced recommendation. So I know this is a much longer version, but what they are saying is that for men aged 55 to 69, they suggest that they should actually decide whether to go for PSA screening or not after talking to the doctor about the potential benefits and harms of screening. So one whole big paragraph, what does this mean? For men with no symptoms, I think there's a lot of you need to discuss with your doctor what happens when you have what will you want to do when you have a raised PSA? You need to know what is the downstream, what's going to happen. So that is what we're going to talk about next. But for men with symptoms, this is no longer screening anymore. Okay, this is testing. So you need to seek a consult. So this is when it's no longer screening. Okay, so what happens when you have a raised PSA? So in the past, I think one of our audience, Mr. Jimmy So just shared that he had a biopsy. So this is a prostate biopsy. So this is, in the past, what we used to do is that we would actually sample the biopsy through the rectum. Through the rectum, we put in the ultrasound, and then we take multiple samples of the prostate through there. So there was a lot of anxiety with prostate biopsy. Nobody says that it's a pleasant experience, like going to a spa. Okay, there is pain, and there is always the worry of infection. But in the last 1 decade, technology has evolved such that there is the use of an MRI scan. It's basically an imaging scan, which and it has been shown. There's a lot of studies in the last 5 years that actually showed that it allows us to detect prostate cancers more accurately, and it helps a certain percentage of men avoid the dreaded prostate biopsies. And with regards to prostate biopsies itself, the technology has also progressed. So these days, we actually have robot-guided biopsies that helps us target the lesion that we see on MRI more accurately. And there's also this transperineal biopsy that we have introduced to NUH, and it has helped us reduce the number of infections after biopsies dramatically. Okay, so after you've had a biopsy, so now the results comes back, and basically you ask, I have been diagnosed with prostate cancer, now what? Okay, so prostate cancer is not just prostate cancer, it's a whole spectrum. But to simplify it, we divide it into localized, meaning early stage prostate cancer is still contained within the prostate, versus metastatic. So it means that this is prostate cancer that has spread beyond the prostate, late stage prostate cancer, and the treatment is very, very different. So for localized prostate cancer, early stage prostate cancer, what can we do? The first thing is active surveillance, what we talk about for Gandalf. Yeah, so the active surveillance is what we do for less aggressive prostate cancer. So there are prostate cancers that behave like pussycats, meaning that they don't grow very fast and they don't really cause any problems. A lot of times they die with the patient, as in the patient passes on from other conditions, not prostate cancer. And then there are prostate cancers that behave like tigers. They spread very, very fast and they're very aggressive, and they will cause problems if you don't treat them. So the aim of active surveillance is that we are just observing those prostate cancers that are like pussycats, and we avoid the problems that comes with treatment. But if the pussycat shows any chance of becoming something more aggressive, we turn into we go into treatment, radical treatment. So treatment includes radiotherapy. So the patient comes in for daily treatments. There are different kinds of radiotherapy. And what happens is that basically they shoot beams to try to irradiate cells in the prostate area. And there's also surgery. So in the past, surgery used to be we used to need a fairly big incision to take out the prostate. But these days, there's keyhole surgery, and there's also use of the robot to actually help us. And this is what the two PMs actually underwent. So this robot guided keyhole surgery. So, I mean, the real question is always radiotherapy versus surgery, which is better? There are many factors that we actually look at. This is a bit more technical, and if you were to go down this road, this is something that your doctor will discuss with you. The short answer is that for cancer control, both are actually equally good, but there are a lot of factors we look at. Patient factors like whether they have any urinary symptoms, whether they have any irritable inflammatory bowel disease, any previous radiation in that area, or tumors. Tumor factors like how big the tumor is, etc. Yeah, but both are good. And now we talk about late stage prostate cancer. So Late stage prostate cancer is basically when the prostate cancer is spread to other places, other organs. And so how we control is that testosterone, which is the male hormones, is actually the fertilizer for prostate cancer. And so when we want to retard the growth of the prostate cancer, we actually block off the male hormones. We can do that with through various ways. We do that with injections, or we do that through surgery. And there's also additional therapies that we may need for this late stage prostate cancer, which is like chemotherapy, oral medications, or radiotherapy. So the aim of all this treatment for localized or prostate or late stage prostate cancer is actually to eradicate for early stage, or to control the prostate cancer for later stages. And we want to maintain the quality of life. It's very important. That means controlling the urinary tract symptoms, ensuring that there's continence, reducing any pain, and also preserving the sexual function. So take-home messages. Prostate cancer is one of the most common cancer affecting men. If you were to forget anything from this talk, you have to remember that prostate cancer is not necessarily preventable, but it is treatable. Detection at an early stage leads to better outcomes. So this is Mahatma Gandhi. I think he's famous for, I'm sure, okay, he needs no introduction. But he's also, one of the lesser known things about him is that he actually walks 18 km a day, every day for the last 40 years before he passed on. And he's the one that says that said, it is health that is real wealth and not pieces of gold and silver. So for all of you guys who bring your cars for annual servicing and all that, your body is the only car that you're going to have for the rest of your life. So it's important to take care of it. So feel free to, if there's any questions about PSA screening, etc., feel free to put it into the chat box. That's all. Thanks.
Thank you, Dr. Wang, for the very comprehensive talk on PSA. So yes, we already have a lot of questions. We will answer them at the end of this session. I thank everybody for their questions so far. So next up will be Dr. Karthik with abnormal findings on my kidney scan. Dr. Karthik, please. Thank you.
Hi, good morning, everyone. Thank you for staying with us for so long. So I'll go on with my talk. Essentially, I'm trying to tell you what abnormal findings mean when you do a scan for your kidneys. Okay, so let's first look at what are some of the common scans that are done for the kidney. I think Dr. Kelvin has mentioned briefly about x-rays being done. Probably the most common scan done in the community is an ultrasound scan, followed by CT scans, which is a computer tomography, and an MRI, which is a magnetic resonance imaging. Both of these are usually done in the hospital setting. And sometimes we do nuclear imaging, also called as radionucleotide scanning, for particular purposes. All right, so this is what an ultrasound scanner looks like for the ladies in the meeting. You would have had this if you've had a child before. This is commonly used to scan the fetus. It is a very harmless scan. It's got no radiation and it's absolutely safe. And this is what we get as an image. It's a grayscale image. And ultrasound is very useful for the kidney. It gives a wealth of information, and there's very little things that the ultrasound cannot see on the kidney. This is a CT scanner. Essentially, it's a donut. This is a souped up X-ray, which is a high radiation scan. So you sleep on this movable bed that goes in and out of the donut, and you get a very conclusive three-dimensional imaging. This does have a certain amount of radiation associated with it, but it is still generally a safe scan. Some people would say that if you take 2 flights back and forth to the US from here, the radiation amount is about the same. Sorry, before that. An MRI scanner looks very similar, slightly bigger maybe. MRI scans usually take a little bit longer than CT scans, but they do not have any radiation as they use a magnetic field to get imaging and not X-rays. So what are X-rays done for? Usually we do them when we suspect someone to have a kidney stone, and they're often used as follow-up methods for people with small stones to minimize radiation but not to miss the stones. So these are what X-rays look like. on the left, you would see a relatively small stone in someone's kidney on the right, and on the left. And on the right side, you see these large stones. This is an extreme example of big stones filling up almost all of the kidney. So X-rays are useful when it comes to stones. This is another imaging called a IV urography. Essentially, it is an X-ray with contrast that is given. Contrast is a dye that is given as an injection, and this dye is excreted in the urine, and you can see urine flowing down from the kidney down to your bladder. And what is this good for? Well, it is good to see abnormality. It may not really give you a diagnosis, but you can see what is abnormal with these scans. And often, on the right side, you can see contrast flowing with the urine, very nicely lit up with no abnormalities. On the left side, you might see some fuzzy things. We call these filling defects. Essentially, these are areas where the contrast is not filling up, and this is indicator of certain disease. And the problem with IVU is this is not conclusive, and usually you will need further scanning or some other investigations to diagnose. So ultrasound, by far, like I said, is the most commonly used modality of imaging for the kidney. And this is because this is cheap and widely available, even by GPs and community centers. And these are good for stones, cysts, tumors, and swelling and obstruction of the kidney. They're very good at diagnosing that these abnormalities exist, but they may not give you the exact cause of these abnormalities. Now, CT scans and MRIs are really very good scans. They give you three-dimensional information, and they're quite accurate generally. And there is very little you cannot see on a CT or MRI. And they're good for most things, including tumors and staging of cancers, and very commonly used in the urology clinic as well as any tertiary hospital that you might go to. I just wanted to speak a little bit on the location of the kidney. Now, a lot of people think that the kidneys are located quite low down, but actually they're a little bit higher than where most people expect. They are partly protected by the last two ribs. So if you can just reach back and feel from the lower of the back all the way up to your first rib, that's about where the middle of the kidneys are going to be. So they are a little bit higher than expected. And this is usually where pain starts when you have problems happening in the kidney. So I would like to discuss 3 or 4 common findings on scans. And I would like you to pay attention to these. If you can take back 2 of these today as take-home messages, I would consider my talk a success. So let's look at some of them. Now, this is something that you would commonly come across. It's called a cyst. So what is a cyst? Cyst is essentially like a blister in the kidney. It is a structure that is filled with fluid. That's what a cyst is. Now, how common are cysts? Cysts are relatively common. If you look at average population, about 10% of the population has cysts, and this increases with age. If you are 60 years old and you have a classmate or school gathering, 30% of you will have cysts, meaning 3 out of your 10 classmates are likely to have cysts. And we do not understand exactly why cysts happen, but we know it is associated with age, and therefore it is a natural process of aging. Now, I've put up here a simple cyst, and this is what a simple cyst looks like. It is completely clear fluid within the cyst. And these are generally very benign. They don't cause any harm, and they very rarely need any sort of treatment. This is what it would look like on an ultrasound scan. It's a very nice looking structure. It is round, very even looking with clear black fluid within it. This is not dangerous again, and can be just, you don't even need to follow up for this. Your urologist will be able to advise you on this. Now, again, this is another example of a simple cyst in inverted commas. I say inverted commas because, as you can see, again, this is on the left kidney, there's a cystic structure with fluid inside. But you can tell that this is kind of pressing onto the kidney and changing the shape of the kidney. So this is a problem that some simple cysts can cause. Again, they are not cancers, but they can just affect by being so big and pressing onto structures that are next to them. And these can cause pain to the patient as well. So sometimes when these cause pain and are pressing onto nearby structures, they may need some sort of intervention, and it's usually a surgical intervention. So not all simple cysts are truly simple. So if we label something simple, you must have the opposite, which is a complex renal cyst. And this is where it gets a little bit confusing. So Bosniak classification is what we commonly use to classify this cyst. Don't get too taken away by the Bosniak classification. It's just a measure of how complex a cyst is. And usually this needs a CT scan with contrast to firmly diagnose. Now, as you can see, the more things you have inside your cyst, the more complex it becomes. Bosniak 1 is a simple renal cyst, so we will just get away with it. Bosniak 2 is when you have a thin septa that goes through the cyst. Now, what is a septa? Septa is essentially a membrane. You know, when you break open an egg and you've emptied the egg, if you look at the shell, one end of it will have a thin film. And that's what a septa looks like exactly. And sometimes when you get more and more complex, these septa can have deposits in them, they can have growths on them. So complex cysts are truly complex, and the treatment or the need for treatment is not clear unless you have had a proper scan and a discussion with a urologist. Essentially, Bosniak 2 is still benign, but anything that is Bosniak 3 and 4, we consider them an indication for surgery to have them removed, as the chance of containing cancerous growth within them increases. So it is quite important to have this done, a proper scan, and have a discussion with your urologist, who can advise you on how to proceed further, whether this cyst of yours needs to be followed up or even have it operated on. The next, I would like to go through a non-cancerous growth that you get in the kidney. By far, the most common non-cancerous growth is an angiomyolipoma. It literally means a growth containing blood vessels, muscle, and fat. And that's what it looks like. You know, it's just a fatty growth protruding out of the kidney. And the real problem with this is that it has a lot of abnormal blood vessels in it. These generally never become cancers. And the problem truly is the abnormal blood vessels. And abnormal blood vessels happen all over the body. And wherever they are, they tend to bleed at some point in time. Half the strokes that happen in the brain are because of abnormal blood vessels that burst open. And similar things can happen with the AML, which is an angiomyolipoma. And this bleeding can be quite catastrophic at times. We don't see deaths due to this ruptured or burst open vessels in the AML in Singapore that commonly. But in countries where the nearest hospital is 1 or 2 hours away, people can die because these bleedings can be quite catastrophic, can be a lot of blood loss. And if you catch this early, the treatment is actually very simple. It's a procedure done by the interventional radiologist, very similar to angioplasty done for the heart. So the radiologist will insert a catheter into this blood vessel that supplies this growth, and they will just block it up with whatever means, either coils or some gels. And that is all it needs to treat this potentially fatal problem. So AMLs are not cancer. We say that the risk of bleeding is greater if the size of the AML is more than 4 centimeters. So that is our cutoff as a department to intervene. And the aim really is to prevent bleeding from happening. It is easily treatable with minimally invasive options, and they're very easily diagnosed commonly again on ultrasound scans. The next big thing is kidney cancer. Nowadays, they're most commonly found accidentally when we do CT scans for other problems, and we often find them at a size of less than 4 centimeters, and we call these small renal masses. Now, 80% of small renal masses are cancerous and 20% are non-cancerous. So if you're looking at scans, either ultrasound or CT scans, the keywords to look for will be solid or solid cystic. So when you see these, alarm bell should be ringing, and you should want to see a urologist as soon as possible to have this checked out and discussed. Now, this is an example of a small renal mass. So this is a CT scan. The kidney on the left looks pretty normal. The kidney on the right, on the top where the arrows are, you see a solid looking lesion. This is a cancerous growth, and this needs to be treated. So if this was diagnosed, let's say 20 years ago, the entire kidney would have needed to have been removed to cure the cancer. But by large, today's day and age, this is what we do. It's called a partial nephrectomy. So we just remove that particular part of the kidney that the cancer is in, and the patient gets to preserve the rest of the kidney, and the kidney function remains okay. And then this kidney can be further followed up to see if the cancer comes back or not. Again, previously it used to be done as open surgery that required quite a large incision, but nowadays we do it with minimally invasive method using a robot. A robot doesn't mean that it's a machine that does the operation. Essentially, it's still very much surgeon controlled. It's just that the use of a robotic arm allows much finer control and leads to less blood loss and a shorter recovery time. The last thing is blockage of the kidney, which we call hydronephrosis. And the problem with this is it can happen without any symptoms. So you may have a blocked kidney and never know about it until maybe even 10 years down the road. And this can be caused by a various number of causes, stones being the most common. Sometimes if you had a previous stone surgery or previous infections, you can have narrowing or scarring of the urine tube, which leads to blockage. You can have tumor within the urine tube that causes blockage. Active infections such as tuberculosis can also cause these. And you can have problems with other organs. For example, a fibroid in the womb, or a cancer in the colon or prostate that can cause blockage of the urine tubes, and this can lead to problems. So this is what it looks like. As you can see, again, the left side kidney looks pretty normal. On the right side, you have a grossly blocked kidney, and I can tell that this kidney has been blocked for quite a while because the black section of the kidney is just fluid and it has very little meat on it. So this is a kidney that's been blocked for a rather long time. And you can see a small stone at the bottom of the kidney. This is not the problem, but the problem is a stone that is not seen here. And this stone has not been causing any pain, but has been blocking the kidney. And this needs treatment. Why does this need treatment? And a blocked kidney can lead to a severe infection because the urine just remains static there. And static urine is a perfect place for bacteria to grow, and this leads to severe infection. It can lead to loss of kidney function. So we say that any kidney that's been blocked for 6 or more weeks tend to start deteriorating and lose kidney function, which then becomes irreversible. And if you're unlucky enough to have this on both sides of a kidney, you can end up with kidney failure if it is not treated fast. So one of the common questions that I get is when is a good time to do a scan, meaning when you don't have symptoms. There's no national guidelines on this. There's no real consensus as well. But just from a personal perspective, I would say when you reach the age of 40, it is not a bad idea to go for an ultrasound scan of the abdomen, which is what I would do for myself. And then we can take it from there. Subsequent scans really is up to you. I would say maybe every 5 years you can get a scan just to make sure that things are okay. But again, this is my personal opinion and there's no real consensus on this. And that's all I have for today. I'm sure you have a lot of questions. We'll try to answer as many of them as possible at the end of the session. Thank you.
Thank you, Dr. Kartik. I forgot to mention that Dr. Kartik works in Ng Teng Fong Hospital, which is also part of our NUHS family, in case anybody wants to look for him. So next up, we have Dr. Chia Jun Yang, who is talking about erections, a common male problem. And I'm passing on the mic to Dr. Chia, please.
Hi, good morning to everyone, and welcome to our talk today. So I'm Chia Jun Yang, and I'm from NUH Urology. So it's coming to almost an hour of talks, and I'm sure your brain is filled with some nuggets of information, and you might be feeling quite tired. But I hope to make it worth your while if you just bear with me for a couple more minutes. So I'd like to let everyone know that my deck of slides do contain several images as well as a video. So that's fortunate or unfortunately, and therefore viewer discretion is advised. So let's dive right into it. How common is erectile dysfunction or ED. There are many studies done out there that has been published, and this is one of the landmark studies, the Massachusetts male aging study. Basically, this study looked at a population of 40 to 70 year old males in a Western population, in Boston in particular. So what they found was that the prevalence of erectile dysfunction, mild, moderate, or severe, was up to 52%. And it was, of course, more common in patients who were more elderly. So, just to give a guide, for mild ED, it was 1 in 5 patients, and for severe ED, was 1 in 10 patients. Next question would then be, why does it occur then? So, to better understand that, let me run you through the mechanism of erections, so that will allow you to better understand our treatment options later. As you can see from the top right hand, there's this picture of what the penis looks like. So erections are a complex interplay of hormones, nerves, as well as our blood vessels. So when there is a appropriate time, when there's sexual stimulation, what happens is that there is increased blood flow into the penis. So as you can imagine, if there was a deflated cylindrical balloon and it was started and there was water filled into this cylinder, it will start to become turgid or hard, and that would then allow for penetration to occur. So next question then, what causes erectile dysfunction? As you can see, there are many causes to it. So I would like to broadly divide it to, firstly, to medical conditions, and secondly, as we all know, sex involves a mental proportion of it that is very important as well. So in the medical conditions, number one, as I've mentioned, aging is very important, and there are many reasons for it. One would be that with aging, there is an increase of other conditions which come along with it, such as cardiovascular risk factors. So this will include diabetes, hypertension, high cholesterol, and even heart conditions. Another big group of causation would also be from environmental factors. So for example, cigarette smoking and excessive alcohol, as that can also tamper with the hormones in our body. A third group would be, as I mentioned earlier, in patients who have previous injury to the nerves of the body, as the nerves play an important part in relaxing the blood vessels to allow for increased blood flow into the penis. Fourthly, hormones play a very important part. As we all know, low testosterone can result in a decreased libido or an interest in sex, and that itself could be the cause for the erectile dysfunction or ED. And lastly, medications would be another common cause for erectile dysfunction. And one of the more common medications which can cause it would be a certain type of antihypertensives or blood pressure medications. Hence, it is important to let your doctor know when you visit him for a consult of the exact kind of blood pressure medications that you are on. And if it's suitable, we can then offer to change it to something that would help to treat the condition. And the last, another last type of medication would be, as what Dr. Wang Ziting mentioned earlier. So during the treatment of prostate cancer, we also give medications to help to reduce the testosterone so as to control the prostate cancer. And that itself can also result in erectile dysfunction. So with all these medical conditions, what are their percentages in terms of how often do they cause erectile dysfunction? As you can see, a majority of it is due to vascular or problems related to the blood vessels, meaning the high blood pressure, high cholesterol, or heart diseases. And diabetes plays the next most common cause for erectile dysfunction. Hence, it is important to control diabetes for patients who have this condition. And the third big group would then be secondary to medications, up to 15%. Now, as I mentioned earlier, psychological or mental causes are a very important cause of erectile dysfunction. So stress can contribute to it. For example, if a patient comes in and just started work, or is having a lot of stress from his environment. Secondly, in patients who have performance anxiety, for example, in a patient who have just started a new sexual partner or first time having intercourse, all these can contribute to erectile dysfunction or ED. And depression and a loss of interest in sex are other common conditions that can cause erectile dysfunction. So what happens at the doctor's visit? Okay, so many a times we would get our patients to fill up a questionnaire, and this is the IIEF-5, which stands for International Index of Erectile Function. So the number 5 there is because this is a shortened version of the actual form, and this 5 means that it looks at 5 different domains. And the whole purpose of this questionnaire is to assess the severity of the erectile dysfunction. So as you can see, this form has several scores. So a score of 1 to 7 will actually give severe erectile dysfunction, whereas a score of 17 to 21 will be mild erectile dysfunction, and above that is actually normal. So the 5 domains, as you can see, would be firstly rating the confidence of the patient for achieving an erection, and secondly, whether how often is hard enough for penetration. Thirdly, how often is the patient able to maintain the erection. Fourth, to maintain until completion of intercourse. And then 5, how often is it satisfactory? So this gives us, this is important because in the assessment of erectile dysfunction, there are 2 components. One is a subjective evaluation, which the patient can then feedback to us. And secondly, this gives an objective evaluation of the erectile function. Another simple tool that we used in the clinic would be this erection hardness score. As you can see, it ranges from 1 to 4, with 1 being severe erectile dysfunction and 4 being optimal erection. So 1 is when it's similar to a tofu, and this is when the penis gets enlarged but is not hard. And this ranges up to 4, which is similar to the consistency of a cucumber, meaning that the penis is hard and completely rigid. So during the clinic visit, it is important that we also evaluate the cardiovascular or the heart condition and blood vessel condition of the patient. So this is because erectile dysfunction can be the first sign of an ischemic heart disease or a heart condition. As I mentioned, because erections is essentially about blood flow, and the penis is what we call an end organ. So if there was a lack of blood flow to the penis, that would then suggest that there could be a blockage somewhere in the blood vessels, and that could in turn mean that there could be problems related to the heart or as well as the blood vessels. A second thing that is very important to evaluate would be testosterone. So as I mentioned earlier, low testosterone can result in decreased interest in sex or low libido. And in these patients, if suitable, what we then do would be to prescribe testosterone replacement therapy, of which there are various forms. So now I move on to the bulk of my talk. What are the treatment options available for erectile dysfunction or ED? So we do this in a stepwise fashion. Conservative meaning non-invasive strategies. Next would be medications, which I'm sure many of us are familiar with. And then I'll move on to adjuncts or procedures. and then lastly, surgery. Okay, starting with conservative measures. So for patients who are smoking can actually cause hardening of the blood vessels, and therefore that can result in decreased blood flow to the penis. So we will then advise for smoking cessation or cutting down the number of cigarettes smoked per day. At the bottom, you can see, of course, a healthy diet is very important. Low salt to help to control any hypertension or prevent it. Low fat diet for cholesterol. And of course, avoid excessive alcohol drinking. And then, not to forget exercise. Exercise is very important because firstly, it helps to prevent all the above conditions that I mentioned. And secondly, it also helps to increase testosterone, which is itself can be a cause for the erectile dysfunction. Okay, so the next treatment option would be medications. So disclaimer, I'm not a spokesperson for any of this company, but as we all know, the blue pill or Viagra is what's shown at the top left. Cialis is the yellow pill on the right side, and at the bottom would be Avanafil, which is a newer drug which has since been licensed in Singapore very recently. So a common question is, are there differences between all these medications? So the answer is yes. While all these medications, they do cause common side effects such as a runny nose, headache, there's minor differences in terms of the other side effects that they may cause. So for example, the yellow pill can cause a more muscle-related aches, whereas the blue pill can sometimes cause a blue vision very rarely. Also, the way of taking these medications also differ. So for example, for Viagra or the blue pill, it is typically taken on an empty stomach. And the reason for doing so is that by eating with a fatty diet, this actually decreases the absorption of the medication and therefore can reduce the efficacy of the Viagra. Whereas that is not so for the other two. One more thing to note would be that for Cialis, which is the yellow pill, it is a long-acting drug. So what that means is that it stays in the bloodstream over a longer period of time, and therefore this allows for a longer time of efficacy. And this is useful for patients who require spontaneity or desire spontaneity. Right, so many a times we see patients who have been started on these medications and still they do not feel the erections are satisfactory. We then advise them on procedures which can be done. So there are namely 3 procedures. The first one will be a vacuum device. The second one will be injections. And the third one will be shockwave therapy. So I'll start off with the first one, which is a vacuum device. So the pictures are very self-explanatory. Basically what happens is the patient presses a button, and with this button it creates a negative pressure within the cylinder. So as you can imagine, with a negative pressure, there will be then increased blood flow into the penis, hence allowing for a hard erection. The second option will be that of an injection. So these injections, basically what we do is that we administer, or rather the patient himself administer the medication into the penis, which helps to increase blood flow to the penis. So I know what you're thinking. The first thing you're thinking is that it is probably a painful procedure. So the needles are very small. They're almost similar to that of needles that diabetic patients give when they administer insulin to themselves. And a lot of times we would teach the patient on how to administer this medication prior to sexual activity. Now the third option would be that of shockwave therapy. So this is a low intensity shockwave therapy, and how it works basically is that it helps to increase new blood vessels. so as to increase the blood flow into the penis and therefore allowing for a good erection and hence satisfactory intercourse. So the following images will contain some graphic content, and I also have a video. So please, viewer discretion is advised. So as you can see, these are some photos of the patient as well as the applicator. So the applicator would then be pressed to the penis, and from this there will be electromagnetic waves. So this would then be distributed across different areas of the penis to generate blood vessels and allow for increased blood flow. Okay, I'd like to now show a video so that it would allow you to better understand what the shockwave therapy entails. Okay, so as you can see, we apply gel on the penis so as to allow for better transmission of the shockwave to the blood vessels and allow for the generation of the blood vessels. As you can see, the patient is lying comfortably on the couch, and typically it's not painful. And in fact, we do not even need to prescribe any painkillers for the patient. The process is done within 20 minutes, and the patient can go home immediately on the same day. And this is typically done about 6 to 12 sessions, with each session done weekly. And the aim would then be to distribute the amount of shocks along different areas of the penis. And here what is being shown is the crura, which is also a extension of the penis. Yep. So that was a video on the shockwave therapy. Okay, now moving on to the last option. So this is when surgery comes in. There are two kinds of prostheses or artificial body parts for the penis. So that can be divided to 1 malleable or bendable and 2 inflatable. So the first option would be a malleable prosthesis. So this is when we insert bendable rods through into the penis, and when sex is not desired, then the patient would then bend the rods downwards, and when intercourse is desired, then he just needs to bend it upright and then perform the activity. The second option of penile prosthesis is the inflatable one. So this is made up of 3 parts. Firstly would be the reservoir, which is then placed in the tummy. The second part would be the pump, which is placed next to the testicles or the balls. And thirdly, the cylinder, which is placed in the penis. So how this works is when the patient desires sexual activity, he would press on the pump, which would transmit water from the reservoir to the cylinder, and by filling it up, create a hard erection. And after the activity, he just needs to press the button next to the scrotal pump, and this would then again transmit water back from the cylinders to the reservoir, and thereby deflating the cylinder and allowing for a flaccid or a flaccid penis. Okay, so that's really it. I'd just like to give some take-home messages. So firstly, erectile dysfunction or ED is not a uncommon condition, and is prevalent up to 50% of the population, especially in the elderly group. And very importantly, it can be the first sign of heart disease. So it is important to get your heart and blood vessels checked up if you have this condition. And in terms of the treatment options, So conservative measures would be having a healthy lifestyle, smoking cessation, eating healthily, and exercising. And medications, there are several players out there, so basically, and there are some differences with each medication. But failing these medications is not the end of the road. There are adjuncts or procedures that we can perform. The first one would be that of a vacuum device in which we create a negative pressure to allow filling of the penis with blood. The second one would be using injections, whereby small needles are used and medications can be given directly to the penis. And thirdly would be shockwave therapy, and this is when we use low intensity shocks. By delivering electromagnetic waves to the penis, we help to generate new blood vessels, and this will help to increase the blood flow to the penis. And its efficacy is ranging about 60 to 80%. And lastly, failing all the above options, then surgery would then be a possible option to look at. And this can be divided to two kinds, whether it's malleable or the bendable kind, or the second option would be the inflatable one, which would be by using water to fill up the penis to make the heart erection. Okay, so that's the end of my talk. Thanks for staying with us and listening to all our talks, and I'm sure we are happy to take any questions that you might have.
Thank you, everyone. Thank you, Dr. Chia, for giving us a very graphic description of all the treatment. I think it helps us a lot because I think it's difficult to visualize when we tell patients, and it's often very embarrassing. So I think the pictures really help a lot. So I will start by answering all the Q&As. Okay, we'll try to group it together, but we may skip some stuff, but it'll be in order. So the first one, the first question is, I went for a health screening in 2019 under my company. They found bacteria in the urine. So I went to the polyclinic and to get it checked. The polyclinic, as usual, didn't find anything. Again, right, the next year, he did another health screening, and this time, right, again, they found bacteria. I did not get it checked, so should I be worried? So personally, I'll attempt to answer this question. First of all, I assume that the bacteria in the urine is found on a dipstick. So for urine dipstick, they usually do it in the it's not too bad because sometimes they do that contamination. But for males, right, for bacteria, I think we need to get it checked because males, right, because of the way they catch the specimen, they don't usually get so much contamination, although it might still happen. Because around the skin, right, there's always bacteria, and the way we catch the specimen is important. But for men, if they consistently find bacteria in the urine, I think we should get it checked. Although when they come and see us, we will ask them about the symptoms. If the patients, right, are asymptomatic, meaning they don't have any pain, don't have any blood in the urine, and there are no voiding problems, right, peeing problems, in other words, we are not so concerned, but we need to make sure that they don't have things like stones and prostatitis. Yeah, these are the things that we actively screen out to make sure that everything is okay. Otherwise, right, most of the time, right, there's no real cause for concern as long as the patient is asymptomatic. But I still advise that we should get it checked. Okay, so the next question would be asking Dr. Kelvin, would this method damage the kidney? This method means shock wave therapy.
Hi, thank you for the question. I think shockwave therapy generally is considered reasonably safe. I think the amount of damage done by these shock waves are very minimal. Most of the time, we don't see any deterioration at all in terms of kidney function or any kidney injury. So I mean, with regards to damage to the kidney, I think that part, unless you're talking about repeated sessions, I think the risk is very minimal. Yeah.
Okay, thank you, Dr. Kelvin. The next question, right? So I'm 83 years old, and I've been going to going for health checkups at polyclinics and hospital over the last 5 to 8 years. So the EGFR, right, is below 60. Okay, so for the rest of the participants, right, EGFR, right, is a measurement of kidney function, and generally, right, if it's above 90, for younger people, it's considered normal. So for this gentleman, the EGFR fell below 60 and it slightly dropped all the way to 33. However, the doctors do not seem to consider this drop as urgent. And I have friends and read credible articles stating that EGFR less than 60 needs immediate and quick action, as that indicates chronic kidney disease. I'm in a dilemma, as the doctors always delay the intervention. Well, it could be, they could reduce the chances of recovery. Overall, I'm quite healthy and mobile and have a controlled blood pressure. So what should I do? Can Dr. Kartik please answer this question?
Hello, hi. So I understand your concern. One of the things to understand with kidney function is kidney function does decline with age. So at the age of 83, most people will not have a normal EGFR, but 33 is a little bit lower than what I would expect. So a couple of questions I want to know, more information of course, is what the trend of the GFR has been, whether it's been dropping drastically or if it's been a gradual decline. And we really need to evaluate the cause for this. Hypertension in itself can be a cause for damage to the kidneys, and the EGFR can decline because of this. But we need to rule out other causes. So if you are really concerned about this, you should see a nephrologist who is a kidney physician to get it investigated and identify the cause, and to see whether this can be treated to prevent further decline of the GFR, of the kidney function.
Thank you, Dr. Kartik. So I would like to add on a bit more to this answer. So I guess it's very concerning when patients see their creatinine levels rising. Okay, because EGFR, right, is related to the creatinine levels, which is a measurement of the kidney function. So as the creatinine goes up, the EGFR will drop. So as long as there's a gradual decrease and the patient feels fine, right, there is no real need for intervention. Because although we are not nephrologists, we do deal with patients with a bit of kidney dysfunction sometimes. And in general, right, unless, right, the patients have in urgent need for dialysis, right, the nephrologists won't be they won't be too anxious about it. So we'll try to reassure patients. And there's a list of indications if patients really need dialysis. Otherwise, in general, the nephrologists, right, we usually try to control the other risk factors such as diabetes and hypertension. So, and then we monitor it. So long as the patient feels fine, right, I don't think there's a real urgent need for any intervention such as dialysis, if that is what the concern is. Okay, I hope this answers the question. So next, we will move on to Dr. Wang Ziting. There are a few questions on prostate biopsy, so we'll go one by one. So I have done a prostate biopsy several years ago, which was found to be benign. However, the PSA readings, right, remain higher than the expected, around 5 to 7. And they fluctuate up and down, and they do not maintain an only uptrend. So the question is, do I need to repeat the prostate biopsy?
Okay, Ken. Thanks, Dr. Fiona and the audience for giving this question. Okay, so I hope you're not too stressed out by your PSA fluctuating. It's a little bit like the stock market lah. So there are many reasons why the PSA can be raised. It could be a big prostate, can be due to infection, etc. But the main thing we are doing is to hunt for prostate cancer. The rest of it is not life-threatening per se. So okay, with regards to your question, we actually need a bit more information. Things like what was actually the results of the previous biopsy, whether there was any inflammation, any other things. We also want to know like the size of the prostate, for example. Then we can go on to decide. There are many modalities that we can use to assess for the risk of prostate cancer besides a biopsy. For example, things like the MRI scan. So short answer is that you may need a prostate biopsy, but we need further assessment. Yeah.
Okay, so another similar question. My dad has prostate biopsy done to determine if he has prostate cancer. His PSA index was high. However, he was advised by a urology doctor to go through radiation therapy, even though the biopsy didn't reveal any cancerous cells. And there was no spread of cancerous cells to his bones. I'm not comfortable with such treatment when the biopsy is not conclusive. What is your advice?
Okay, so very interesting question. I think you are right to question whether we should actually whether radiotherapy should happen. I think the key it is unusual to offer radiotherapy when there is no confirmation of any cancers. I think the key is in the result of the biopsy. We really need to take a look at it because to actually determine whether what. I think the key is in the biopsy, to be honest, the pathology. Otherwise, it's too early to say.
Thanks, Ting. So I guess I think what we are trying to say is that we should get a second opinion if required. And sometimes, right, when patients come to us for second opinion, we do review the histology slides again to see whether there are any cancerous cells. Even a minimal cancerous cells, right, we would discuss, and then we will get back to the patient. I think that's important, and your concern is right. So hopefully that helps a bit in answering your doubts. Okay. So another question, right, for Ting. I think we will clear all the prostate cancer questions first. Could a benign and large prostate turn cancerous unknowingly with persisting elevated PSA?
Okay, thanks for all the overwhelming interest in prostate cancer. Okay, I think it's not really, let's just rephrase it a bit. How do we know that it was a benign and large prostate cancer in the first place? Probably that patient had undergone some form of evaluation, maybe a prostate biopsy. So how accurate is a prostate biopsy? So for example, it can be less accurate in a patient with a very large prostate. For example, imagine you are playing like battleships and you're trying to target a small lesion in the prostate cancer, in a large prostate. So sometimes there's a risk of missing the prostate cancer. So it's not that it can turn cancerous. It's just that there was a small lesion in the prostate that was missed on previous biopsies. So that is also the reason why we actually persistently monitor the PSA even when we think that there is a benign when we think that there's a benign prostate. Yeah, we still need to watch out for the possibility that there is a cancer growing inside.
There was another question, right, that's very similar. Does high PSA mean cancer? Biopsy did not find cancerous cells, and how accurate is PSA?
So PSA is like the signal indicator on the car. As in, it can tell us that maybe something is up, but it does not mean that it's cancer. Okay, so can mean other things: big prostate, infection, person just ejaculated, etc. So it's hard to say, but that's why we need to do further testing. Sometimes we even repeat the PSA after the first time it actually comes down. Yeah, a lot of factors to consider.
So what we are saying is that we don't have to be very anxious when the PSA is high. We should get it checked. So what is the recommended age for PSA blood test?
Okay, increases with age. Right now, there is no official guidelines. They basically range between 50 to 55 years old and above. But sometimes in a very, very strong family history, we may actually test a little bit earlier.
Okay. How often should we do a PSA test after the first test?
Okay. So, great question. So this actually depends on a few factors, such as your age, such as the PSA levels, for example. I think previous studies in US, Copenhagen, have shown that in if your PSA is less than 1 and you are like 50 years below, the chances of you passing on from prostate cancer in the next 10 years is actually very, very low. It's less than 10%. So in general, most of the time we will actually increase the interval. But in a borderline kind of PSA, that is not raised. We generally will repeat it every 2 to 3 years.
Okay, so is increasing trend of PSA reading a concern?
It is okay. So the absolute number is one thing, and the trend is also another thing. So for example, from for 1.0 to 1.01 or to 1.05, that's not particularly concerning. But if you are borderline case, for example, 4 to 4.5 to 6, then that's when we really need to rack our heads to see whether are we missing out a cancer. Yeah.
Zhe-Ting, do you want to talk a bit about other kind of tests other than PSA, like prostate health index that you may see when you come and see the urologist?
Okay. So in the recent few years, there are adjuncts to prostate cancer, meaning a more test that also gives us additional clues. So remember that previously I mentioned about the pussycat versus the tiger. So we are not trying to catch the pussycats because they are the ones that will stay inside the patient's body and not cause any problems. So this new blood test that we do, like for example the prostate health index, other form of blood test, urine test, and other form of scans, for example, they are the ones that help us find the tigers in that sense. Yeah.
Then should PSA be done if the diagnosis is BPH?
Should PSA be done?
If the diagnosis is BPH. So in other words, should screening be done if the diagnosis is BPH?
It depends on how the diagnosis is formed, for example, it depends, and also if the patient's age and other comorbidities. I mean, the short answer is that if you have low urine tract symptoms and you have not had any evaluation to confirm that it's BPH, I would suggest that PSA be done for the appropriate age group.
Yes, I agree. So one of the question is, this one is a bit difficult. So we'll try to answer it in all. What conditions can one fall under active surveillance for prostate issue?
Okay. So I suppose, okay, the first thing is to confirm that the patient has had prostate cancer, that is via biopsy. So within the biopsy itself, we actually look for a lot of things on the tissue that tells us that this is a pussycat. So we want to look for that. We want to make sure that the tumor is not such a large volume disease, and also so that is based on the biopsy. We also want to look at the cells itself that tells us that it's not so aggressive. We also look at the PSA levels and the trend of the PSA, etc. So all these things tells us whether you are suitable for active surveillance or not.
Okay, then my PSA is always high, about 5.4 and above, but nothing in the urination, no issues in the urination. CT scan shows no growth in prostate. So the doctor advised continue doing PSA check yearly. Should I be worried?
Okay, 4.5.
5.4.
5.4. Okay.
CT scan done, showed no cancer.
Okay.
So they want to do annual PSA.
So first up, CT scan is not accurate for prostate cancer. Generally, what we use is the MRI prostate. Okay. So CT scan is not validated for that. I think there needs to be a lot of things like physical examination to evaluate, and also your risk factors. At a level of 5.4, everything, if there was a tumor, it was too small to cause any symptoms. So I would say symptoms are actually not so accurate for the detection of prostate cancer, but definitely need to monitor and further work up for that raised blood test.
Okay, so another question. Besides prostate cancer and age, what are the other causes of enlarged prostate gland and continuously high PSA? I think Dr. Wong mentioned just now, one of the other causes of high PSA would be prostatitis or urinary tract infection. So in general, when patients have infection, right, we don't usually advise them to do PSA because it can be elevated temporarily, and this causes a lot of anxiety. So when you have active, like painful urination, you're just not feeling well, right? We don't advise doing PSA. But if you have done it, don't worry. We will just need to repeat it in clinic. Okay. So after treatment for prostate cancer, how often does investigation still need to be done?
So when we are talking about treatment for prostate cancer, I assume that we're talking about localized prostate cancer, for example, radiation or surgery. Then usually what we do is for the first 5 years, when there's a greater chance of recurrence, we tend to monitor in the intervals of 3 to 6 months. Then we extend it to 1 year. Then we will increase the interval subsequently. Yeah.
Okay, thank you, Zhe-Ting. Then the last one, I think for you. My father is over 80 years old and he has very high PSA reading. He has been on a prescription of aspirin as blood thinner and other medications to control hypertension. Could this medication have affected his PSA level?
Okay, typically blood thinners, blood pressure medicine, everything, they don't affect the PSA levels. There are other medications, but not those. Other medications that we use to control urinary symptoms, for example. But again, your father is quite advanced of age. So how far we decide to investigate will also be determined by the level, how high the PSA is, and also his other comorbidities. Sorry, yeah.
Okay, so the last question, I will help Dr. Wang to give her a break. How can I arrange for my first PSA? Basically, we do a blood test. PSA is a blood test. So when you see your GP, right? Okay, if you're of the correct age, that is what Tzu Ting says, 50 years and above, right? Yeah, you can do one. Okay, most of the time, right, people do it during health screening. So so you find out whether it's normal or not. Okay. Now we move on back to Dr. Kelvin about stones. Is there a limit of how much water we can consume to prevent kidney stones? Are there any concerns with overconsumption of water?
There definitely are concerns of drinking too much water. Such as old people drink too much water, they can get fluid overload. It means fluid starts to collect outside of the system in the lungs, as well as in the legs. So in general, when we say drink more water, right, it really depends on whether you are never formed stones before or whether you are a frequent stone former. So for somebody who keeps on forming stones, we will say, yeah, you really need to increase your fluid intake. And aim for urine production of about 2 liters a day. But for someone who has never had stones, just the general population, like I think I mentioned a bit earlier, was that it also depends on your activity level. If you are always outdoors, you need to increase. If you are mostly indoors, you may not need to drink so much. So look at the urine color. If your urine color is generally quite pale on the lighter side, it means you're reasonably well hydrated enough. Yeah, I hope that answers the question.
Okay, what foods to avoid to prevent kidney stones? And stones are formed from calcium, right? If not, why? If so, won't taking calcium-rich food cause stones?
That's a very, very good question, very astute question, because we know that one of the components of stones is actually calcium. Then how come we still need to take calcium in order to prevent stones, right? So it sounds a bit contradictory. Now the reason is quite complex. The mechanism is not so simple, but in general, your body needs a certain level of calcium, to maintain normal daily activity. So if you keep on having a malnourishment of calcium, your body will try to harvest calcium from other sites. For example, your bone. So you will try to take the calcium from the bone to maintain homeostasis. And from that, you get osteoporosis. And on the contradictory side, because of this, you actually have increased secretion of calcium as well as oxalate in the urine. So these are all pro-stone formers, and then you end up having a higher risk of forming stones. So calcium is actually a moderate intake of about 1,000 to 200 milligrams a day is actually important for us to actually prevent stones from forming. So you can actually look for calcium in your diet from foods such as cheese, milk, tofu, or even green leafy vegetables. Yeah.
Okay, this is my favorite question. How does eating meat? Is eating meat one of the risk factors of kidney stones? What is the mechanism?
I think in general, we should all moderate, whatever, everything in moderation. Of course, I'm not saying that you cannot take meat, and meat is an important source of protein. But of course, overconsumption of meat, the risk of you having increased secretion of uric acid in your urine because of that, can also predispose you to forming stones.
Okay, very good. So in short, right, don't eat too much meat. And I think another thing, you need to tell patients, right, drink more water, don't take too much salt, don't take too much meat, and then our favorite, peanuts. I think a lot of Asians like peanuts, so peanut can be quite bad. In all, right, it's not only the calcium, it's oxalate. So when we take too much meat and we take too much offals, right, or organs, then that one will cause some risk of kidney stones. Just be careful. Okay, another question. I had 9 bladder stones removed 5 years ago. Are they similar to kidney stones in terms of causes?
In terms of causes, most likely not. Of course, stones can drop from the top and then end up in the bladder. Stones can also form primarily in the bladder, which I think is probably what you had. When stones form in the bladder, it could be because you're voiding. That means your urinary emptying from the bladder is suboptimal. So when you have suboptimal passage of urine from the bladder, maybe because of prostate hypertrophy, there is stasis of urine in the bladder. Now, this urine that doesn't get emptied regularly tends to become concentrated, tends to become dirty, and they form like a very ideal conditions for all these stones because of urinary stasis to form. So the reasons of why primary bladder stones form and kidney stones form is slightly different.
Okay, so just now we mentioned when we do repeated shockwave therapy for kidney stones, right, the kidney will deteriorate. So how much is too much?
In general, we will not advise patients to continuously shock the same stone, for example, in the kidney, over and over again. You know, that's why after the first session of shockwave, we would see the patient again in the clinic. If there is still some stone left behind, maybe a second shock, and rarely a third session. We rarely go beyond 3 sessions. So in general, the amount of shock exposure to the kidney would increase your risk of having kidney damage. Nobody actually knows or studies how much nephron or kidney cell loss there is associated with every single shock. But so far what we've seen is that it's a reasonably safe procedure with regards to kidney function. Yeah.
Okay, now we give Dr. Chen a break. Move on to Dr. Kartik. So if MRI scan is radiation-free and safe, why do we do CT scan?
That's a good question. So because historically CT has always been used, so this is one of the scans that most people are very familiar with reading, and for fluid tissue interface and the pelvic colorectal system, we prefer a CT scan because it enables to see things better than an MRI. We do get an MRI specifically when there's a question of soft tissue that needs to be evaluated that the CT cannot give you answers, or when your kidney function is not adequate enough for a CT scan, then we get an MRI. But by and large, MRI is not default. CT is usually our default.
Yep, thank you, Dr. Kartik. Another one, I have protein in my urine. How concerned should I be?
Right. So protein is in the urine can be very insidious. It can mean nothing or it can mean something very grave. And usually this needs to be evaluated as to what it actually means. And so this can be done in the polyclinic as well as in the hospital. Essentially, they will look at the ratio, how much protein there is in your urine, and the ratio between the protein and creatinine. Generally, we don't expect protein there to be protein in the urine, mainly because it's a very large molecule. Now, imagine your kidney as a filter, like your coffee sock filter, and protein by right should not go through this filter, which is the kidney. But whenever there's damage that happens to this filter, holes will appear, and the protein squeezes through these holes and ends up in your urine. So protein by large could be an indicator for early kidney damage. Now, this needs to be confirmed to ensure that yes, there is protein again consistently, and it needs to be evaluated. So this can be done in the polyclinic or with a nephrologist. It can indicate early kidney disease.
Okay, so about the renal cyst now, right? Is there a concern if the cyst has grown in size? Do I need to go for consultation if I need to urinate frequently at night, though not every night?
Okay, so 2 questions there. First question about renal cyst. Now, I'm assuming that you're referring to a simple renal cyst because complex will always be followed up. We expect all cysts to increase in size, roughly about 3 millimeters every year. And it is expected. Some cysts don't grow at all. Some cysts can get smaller, but we are not surprised when we see the cysts grow in size. If it is a simple renal cyst and it's not causing problems, generally you don't need to follow up for these, unless they're growing at a very fast rate. If they're stable, you don't need follow up. The second question about urination. Sorry, Dr. Fina, I didn't get that. Was that nighttime urination?
Yeah, nighttime urination. Not always, but sometimes.
So this is occasional nighttime urination.
Yeah.
It can be contributed by many things. Usually it's a water intake problem. People don't realize how much fluid there is in our food, especially if you're having a late dinner or you're going to have soup for dinner. This can increase your chance of having urination at night. And if you sleep in an air-conditioned room, if you sleep for more than 8 hours, a night, you can wake up at night to pass urine. And it really depends how much urine you produce at night. And the main indication to treat or evaluate this is if this is troubling you. If it's troubling you, not allowing you to get adequate, good quality sleep, then I would advise you to see someone to have this night urination evaluated.
Okay, so Mr. Singh is asking, I have kidney cyst. I've been going for annual kidney ultrasound. The size of the cyst is the same. So is the annual ultrasound still necessary?
So, this was Charanjit, right? So if it is, again, a simple cyst, not changing over the years, actually you don't need to follow up. But again, please check with the doctor who's following up. Make sure this is a simple cyst and ask them for advice if you really do need a follow-up or you can be exempted from follow-up, and they will give you the answer.
Yeah, I agree. Okay, so next is Mr. Ong. My creatinine reading was 137, which was borderline, 70 years old. EGFR was 52, and he had red flags during screening. So he consulted a urologist, and he's taking a course of ketosterol and ProSafe Forte. Okay, so I did a bit of reading. Ketosterol, right, is amino acids, right, for CKD, and ProSafe Forte, right, is for prostate. In case the rest of us don't know. So he had a urinary infection early this year. So what can he do to normalize his situation?
Okay, so to normalize the situation, I think, again, a couple of things here, right? So one is the raising creatinine. The second is the UTI. I'll address the UTI first. It's a bit uncommon for men to get UTI, and the fact that you have been given some kind of treatment for BPH indicates that you may have a prostate issue, and sometimes that can lead to an increased residual urine. You may not be able to empty your bladder well, and that can predispose you to getting urine infections. So generally, urine infections in male is investigated, especially if you're seen at a urologist. I'm sure at least ultrasound has been done. And this can exclude other causes of infection, such as stones or growths within the urinary system. As to the rising creatinine, again, rarely is it a urological problem. It's usually a nephrological problem, which means, again, the filter in the kidney is an issue. And damage to the kidney can be caused by many things, including high blood pressure, diabetes, obesity is another commonly missed out cause, as well as any medications that you can take that can injure the kidney. So again, this needs to be evaluated properly to ensure that we can prevent further loss of kidney function, and you can live the rest of your life with the remaining kidney function that you have.
Okay, the last one for Dr. Kartik. Why do people have blood or protein in the urine, and how to prevent it?
So again, protein I've already covered, right? So it's the filter that is damaged and then protein squeezes through. In the same manner, blood cells can squeeze through as well. The other causes potentially for this, if there are stones in the kidney or if there are growth or tumors along the kidney or the urine tubes, you can have protein and blood in your urine as well. Which is why if you have too consistent reading of blood in your urine, we would evaluate you completely with some form of scan to look at the kidney and the urine tubes, and also a cystoscopy, which is a camera test into the bladder to again ensure there's no what I've mentioned, stones or tumors within this. The chance of having anything significant like a stone or a cancer when you have microscopically detected blood in the urine is roughly about 3%. So 97% of times you're fine, you're all right. 3% of times you may have something that needs some form of intervention. So that is what, in a nutshell, blood in your urine means.
Thank you, Dr. Kartik. So now we'll move on to Dr. Chia. Are radiotherapy and hormone therapy the main culprits of inability to maintain an erection and semen or sperm production? I think this question, from the question, right, I think radiotherapy and hormone therapy, the person means treatment for prostate cancer. Yeah. So is it the cause of erectile dysfunction and abnormal semen production?
Yeah. So, yes, so for radiotherapy, what it does is that it can cause erectile dysfunction, and this is because there's injury to the nerves. So as I mentioned, the nerves are important for increasing blood flow to the penis. And it depends on the type of radiotherapy that is given. But the risk of erectile dysfunction can range from up to 50 to 60%. And similarly for giving hormone therapy, or what we call androgen deprivation therapy, what it does is that it can reduce the testosterone level. It can also result in a decreased interest in sex or decreased libido, and all these would contribute to erectile dysfunction. But having said that, as I mentioned, erectile dysfunction is a complex problem which, other than these culprits, there's also the underlying conditions within the body. So for example, if that particular patient also has a high cholesterol or diabetes which is not well controlled, all these will also contribute to erectile dysfunction.
Yeah. So with every treatment, right, there's always some side effects. So yes, the treatment for prostate cancer does have some side effects. I hope this answers the question. So there's another question. Ejaculations are beneficial to prostate health. So will regular ejaculations prevent prostate cancer?
Okay, thanks for the interesting question. So actually, this is a very common question. The short answer is that there's no good studies to show that ejaculations will prevent prostate cancer. But having said that, there is a group of patients that we see who have blood in the semen, or what we call hematospermia. And more than 95% of these patients who have hematospermia or blood in the semen is actually from a benign cause or is non-cancerous. But having said that, rarely it can be due to something which is reversible or treatable. So if there's a patient who has hematospermia or blood in the semen, then what we would recommend is for him to come to see us for evaluation.
Okay. What common type of antihypertensive drug causes ED?
Okay, so there are many classes. So the two main classes or subclasses of antihypertensives would be what we call the beta blockers, or those that ends with a LOL or LL. So an example would be like a tenolol. And the second class would be what we call the angiotensin blocker, or the ARBs. Angiotensin receptor blocker. So basically, these are the ones that ends with like sartan. So like besartan, for example. So if you're on these two subclasses of antihypertensives, then one thing that we can do would be to switch to a different class of antihypertensives, such as the ACE inhibitors.
Thanks. Then another one. For inflatable penile prosthesis, the device uses water to make it rigid. So will the fluid leak out from the device, causing problems to the penis? Will the fluid need to be refilled?
Yep. So yes. So in fact, one of the things that we counsel to patients when we advise for surgery would be that of a device failure or leakage of fluid. So this is essentially still a mechanical device, and it's like any appliance that you use at home. There's always a chance of failure. So during this insertion of this device, what we do is that the company actually gives a warranty. So if it happens to be due to a device failure or mechanical failure, this can be then replaced. But having replacement would require either revising the part which has malfunctioned, or sometimes it may involve removal of the whole device.
Yeah, thank you, Dr. Chia. So now we will, the rest of the questions, I'll try to answer. Okay, Tzu Ting, answer this one first. My PSA reading is very high. I'm taking medication to ease the passing of urine. Could this medication elevated the PSA level?
Okay, interesting. Okay, the medicine typically, if they do change the PSA level, they will actually reduce it rather than increase it. So if it's increased anyway, we would still have to investigate.
Yes, I think we need to investigate. So the attendee who asked the previous question, right, about the benign prostate turning cancerous, right? Biopsy and MRI clear. So how to continue to monitor this raised PSA?
Okay, so biopsies, there are different types of biopsies, for example. So we need to evaluate that also. For example, 6 as in you take 6 samples in a 40-gram prostate versus you take like 20 cores in a 20-gram prostate. These are two different things. Now, as in what we are trying to say is whether there is sampling error or not. If it's really extensively biopsy, then I would say chances are there's not much to worry about. Yeah, you can go and celebrate.
Okay, so I'll try to answer this question. How effective are supplements like nettle, saw-palmetto, pumpkin seed compared to drugs for managing BPH? Besides managing the symptoms, what are needed to monitor the growth and prevent it from turning cancerous? So, from all the literature, right, all these medications, all these herbal medications, right, the results, right, are actually is controversial. So we mean that some studies show that it helps, some show that it doesn't help. So of course, when compared to medications, right, they are not as good because the medications are very targeted and they target the prostate itself, and either making it shrink or making the prostate relax so that patients can pass urine properly. So I would say that you can take the herbal medications if you think it helps, but in general, right, I think if it's really bad, medications do help better. And besides managing the symptoms, what are needed to monitor the growth? So basically, we go by symptoms. When you see us in the clinic, we will check your flow. We will ask you, how do you feel? Do you pee a lot of times at night? Is the flow slow or this? So that we can help manage the situation better. How to prevent it from turning cancerous? I would say that it's difficult, okay, because as we age, our cells will undergo changes and some cells do become cancerous. So despite our best intention of taking supplements or this, right, a certain number of patients do still get cancer. So in the appropriate age range, right, like what Dr. Wang said, right, we have to monitor the PSA. And if we detect prostate cancer, whether early, hopefully early, then we will get it treated. Yeah, I think, this is the answer for this question. And then we have, I consulted a urologist. This is by, I think, Mr. To. I consulted a urologist at Changi for my frequency of urine. He went through many tests, urine, ultrasound, PSA, and all are good. The urologist prescribed solifenacin, that's Vesicare, to be taken in the morning. Then the patient was taught how to control his bladder and how to do his daily recording, which is what we call bladder diary. So the past month, right, he shows he drinks average about 1.8 liters and 10 times a day, and total, output is about 1,700. I think that's fair, but what I assume what he's asking is whether it's okay. So the Vesicare does help in the frequency of urination, okay? So it's about 10 times. So it also depends on what the patient drinks, okay? Because we don't have a complete picture here. So in the bladder diary, right, there's actually, right, what sort of drink, you take a day. So basically, normally when this patient sees us, right, we advise them don't take too much caffeine. I think a lot of us take caffeine, like Kopi O, our favorite, that one causes a lot of urgency. So, of course, if you average 10 times, right, you need to see how much is the volume. So if you drink a lot of water, the volume is quite good, and you're not bothered, you don't leak, I think that's good enough. Okay, so we go by symptom management. Vesicare is a good drug, okay, it's quite new, so it causes the least side effect in this class of drug, which is called anticholinergics. So if it doesn't help you enough, right, sometimes we add on medication. But the medications are a bit more expensive. And there are of course third-line treatments, but this I think the urologist will discuss with you. Okay, I hope this answers Mr. To's question. Okay, then one of the questions, which hospital is renowned in urology in Singapore? I would love to say there's NUHS, but the fact of the matter is I think all of us are trained in Singapore. We are all accredited urologists in all the government hospital, private hospital. Nobody is, extremely, I would say that extremely good, because in general, all of us know our subspecialty quite well. As long as the treatment, right, is good, I think you keep to the urologist. But of course, I always tell patients this: if you feel uncomfortable, then please ask for a second opinion, because I think everybody deserves, right, another second opinion. Oh, another question. Okay, I try to do this fast. Okay, the one patient asked, if I always have the urge to urinate when you're going to bed or at home, it can be a few times, the urine very little. So is this an issue? I think what the person is describing is a bit of overactive bladder. So yes, you need to see a doctor for it, because if it disturbs you when you're going out or it already affects your life socially, you dare not go out, or you need to go and look for a toilet whenever you're in the mall, right? Then yes, please see a urologist. Okay. Okay, I'll answer one last one. Any way to strengthen our kidney? The answer is don't get diabetes and don't get hypertension. You can't strengthen the kidneys in Western literature, Western medication, but you can prevent it from getting bad. I think that's what we always tell our patients. Okay, I think time is running out. With this, I'm so sorry I cannot answer all the questions, but I hope this has helped you and everybody, and I hope to see everybody next year live, so that when we can have a real Q&A with face-to-face. I'm sure a lot of the attendees today are our patients or our regular annual NUH symposium attendees. So I thank everybody for the time spent with us today, and I hope you all understand a bit more about urology, and I look forward to seeing you all again. Thank you, everybody. Thank you for making the time today.